tumors, the Sando or Lamino, or is it something because of our behavior? Staying up late while we ate? Is it a physical? I want to blame it on the tumors or something.
I mean, I have a lot of thoughts. It's probably the most common thing I talk about in a day. Everybody with NETs feels tired. Frankly, everybody with cancer feels tired. I mean, just if you're jammed into the medical industrial complex and you don't feel tired, then you're probably not paying attention. So there's that. There's a lot of physical components, and they can be extremely varied. They can be endocrinologic. Perhaps thyroid's been derailed by some of the therapies that you use. There's likely some things that we don't understand about the secretory nature of neuroendocrine tumors that I think contribute. Nutritionally, things are often very difficult and completely changed. Nobody with neuroendocrine tumors really has a normal GI tract. Anything that's coming from below the diaphragm, everything's disrupted, so what you eat's thrown into upheaval. There's stress. I mean, I think it's an odd stress relative to other cancers. I think, as I said, most patients are told, yeah, you have a cancer. Well, it's a good type of cancer, so you don't need to worry about that. And then you show up, and I'll very intentionally try to avoid discussing prognostic numbers and everything else. I think we heard from Representative Castro. He was told that he had 5 to 7 years to live, and I just will tell everybody, I don't know. I don't know how this is going to go. We have some ideas, and I have some predictions, but things may not go exactly like I think they will. So nobody really sleeps very well, and that may be an endocrinologic problem. It may be a stress problem. Psychologically, it just kind of throws everything off. That can be fatiguing. I really loved that last presentation from Jessica about just kind of the things in therapy and such. We're not going to talk to you about that stuff. That's not really how we're trained. It doesn't mean that we don't think it's critically important. I wish everybody could get therapy. Not everybody can. I'd recommend it to everyone, frankly, everybody who's practicing medicine. So I think all of those things go in together. So there's many different factors. It's extremely individual. Some people have really organic reasons to be stressed, complete disruption of the neurohormonal axis. Some may be an effective therapy, and some may be situational and psychological. But it's the most common thing I talk with patients about. I would say number one, feeling tired.
I felt very tired even before I was diagnosed. I think that might be like a sign of that you have something going on, that it's forming, even before you get it.
Agreed. Most common symptom, would you say? Fatigue? I would say most common symptom.
Should I come up to the mic? I just want to.
Sure.
Yes, please.
We've got some written ones too, but we'll work through those.
I want to know if you all still find the Ki-67 marker, is that still used pretty regularly? Yeah?
Yes. Next question.
Well, okay. I don't know. I put a lot of emphasis on that particular marker because that's what I was told, but now it doesn't seem to be as useful as it was.
I think what I would say is Ki-67 still remains important. I think in the big picture, what we yeah, I'm sorry, I'm always going to make them turn up the mic. In the big picture, I think that we globally appreciate that the faster a cancer is growing under the microscope, I think that raises our concern about how quickly it might grow in the person as well, while we also appreciate the weaknesses of that test and the variability that you'll find just based on who looks at what cut of what slide on what day that came from what needle that was put in what tumor. I think I got all the variables right there. I do think, though, that the other part of it from a management perspective is that while it can affect our anxiety and sleep to see that number, when we think about the therapeutic approaches these days, we typically rely more on that appreciation of the differentiation status. And so sometimes we can get away without the most precise understanding of the
Yeah.
Key 67, at least when the risk of reassessment from additional procedures may be more than, the benefit that we might get for determining what we're going to do. So not to be too glib the first time, but yes, still important with some caveats.
Okay. My second question has to do with the Ipsen lanreotide injection that many of us get, and that it was recently changed to a generic form, Cipla, I think is the name of that. And I wondered if any of y'all have seen negative reactions in any of your patients after they've been switched from the original Ipsen form to the generic.
Yeah, any patient switch? Anything else? I haven't.
Yeah, no, I also, I think this is one of those spots where I think we just have to sort of, as Scott said earlier, sort of lean on the FDA a little bit and the regulatory pathway that was taken.
Right.
I don't think I would have a firm, I don't think I've received information that would make me think in any way that one was preferable to the other.
Okay.
I'd agree.
All right, thank you.
I have a question of how can research dollars be increased significantly for NETs? We're all here?
That question was from me.
Dan's handwriting.
A related question. Dr. Paulson and Dr. Halperin, you were both talking about that it would be valuable to have patient advocates participating in this interaction as trials are designed. If anybody here wanted to do something about that, how do you become a patient advocate?
It's a good question, and we were just talking about this outside, actually. There's really what I'd advise, and there's a number of patient organizations that can kind of help prepare you on it. If you do go that direction and really want to be involved in that, I would advise spending some significant time trying to prepare and organize so that you have a very, very coherent argument, for lack of a better way to say it, coming in. I think the patient advocacy groups and the research foundations that are associated with NET can often provide ways. There's a couple of folks who have really established essentially a career in being patient advocates in neuroendocrine tumors. And honestly, prior to neuroendocrine treatment has changed significantly since I first started doing it 10, 15 years ago. I don't know how long now. And really, a lot of it was driven by patients. You guys needed to band together and figure things out because it was pretty frayed apart, even in the academic community. So I think there's a lot of different opportunities. You can usually start online or through one of the organizations, and they're going to be able to try to get you connected in with industry folks, but usually they're going to also want you to be kind of prepared going in. It's a lot more effective. A lot of these things are decided actually fairly quickly, believe it or not, quicker than you may think, even though they're really expensive trials. So being able to prepare an argument and have a really good kind of thought process of what you think is important and understanding how a lot of the trials have been run in the past is important. And that's where we'd rely on organizations to try to help do that.
Add to that, and this is especially important for rare diseases, where collectively you are a large number of individuals. So a quarter of patients that have any disease have individual rare diseases. So collectively you are very powerful. Individually may not feel like that. So I think there is an increasing interest in patient-centered research and patient-initiated research. So take full advantage of that because this has moved many fields. There is a rare tumor, angiosarcoma, that had a couple years ago initiated by patients. They found a way to create a network around the world. And by themselves organizing and collecting samples, they were able to create a research project that was funded eventually by the NIH and the Broad Institute at Harvard. And they found mutations that caused these tumors, and that led to targeted therapy. So that was initiated by patients, and within a relatively short period of time, that led to a treatment that was not existent before. So I think this is a good example of how powerful patients can be when they organize and get involved in their disease. And I think it's a really good example of how you can also be a part of the changes.
Hi, so I'm Elsa Gabriela, and I was recently diagnosed last year, and I have a tumor in my liver. I wanted to know if there's anybody else here who has the tumor in their liver. Because they say that the tumor that originates in the liver is very rare. I got a second opinion, and they said it originated in the lung, but then I was reading that it's not really for sure. Like, it's most probable. So I have this doubt, like, why is it so rare for it to originate in the liver? Or what is this thing with the...
I think historically, it's always interesting when you get to see slides from smart people and notice correlates, right? So you heard about chromaffin cells in the adrenal glands in Dr. Dahia's presentation, but we typically think of neuroendocrine tumors in the gut in particular, but in the GI tract coming from enterochromaffin cells, which are close cousins, which is why we spend time together thinking about these things. And so those cells, tend not to exist in the liver in sort of normal states. So the thinking is that it would be relatively unlikely for those cells to be able to start dividing out of control in the liver and form a tumor because they weren't there in the first place, as opposed to islet cells in the pancreas or enterochromaffin cells in the gut, or the known epithelial endocrine cells in the lung as well. So that is at least the genesis of the argument that the liver tends not to be a potential primary site, at least in my understanding. Certainly welcome other folks' thoughts on that.
So it's very rare, so do you know anybody?
I certainly think at least twice in my career that there's been biliary primaries or liver primaries. But like Dan was saying, we think it's not necessarily where those cells are supposed to go, but we also don't understand the neuroendocrine system all that well. So I do think it's possible, but the general teaching I'd give to my fellows is if you think it's a liver primary, you better find where it actually came from. That being said, I do think there are times where it is certainly potential or possible. Identifying the source of origin is not always critical. We want to know it, but it's not always critical. So you may still be able to perform treatment in the standard way that you would without having that question completely answered.
I have a follow-up on that one. What about ovarian? Ovarian that
It happens.
I have, yes, it does. I have it.
Yes.
Is that how is that kind of would fall in the same region? Is it? I mean, how would? Oh, I hate these things. How would it?
Yes.
I mean.
Yeah, I would put that in the
How?
same category of being exceptionally rare. Ovarian tissue, just scientifically, there's a lot of things that aren't necessarily purely ovarian tissue coming in there. You can have all these kind of mixed phenotype tumors that can come from the ovary. If you think about what its natural function is in creating new genetic code anyhow. So there's a lot of very different ovarian tumors that can come out and develop into many things. It's where you can see these things called teratomas, which will have things like hair in it, okay? So there's a lot of different things in the ovary. It's not the densest area, again, where you're seeing those enterochromaffin-like cells, and their densest concentration is going to be small intestine, lung, where you're having other neuroendocrine primaries in a dense region, the islet cells, pancreas, thymus, these are there, but ovary is potential. We think that basically these can kind of come from anywhere. There's neuromuscular variants, usually associated with something called Currarino syndrome. There's a lot of different types of neuroendocrine tumors.
So I'm gonna come on and piggyback off of her then. So after that tumor has been removed, but the doctor's convinced that that is the primary and that's the only tumor, how do you get them to move forward to something else? Because I haven't been to a specialist, only regular, the oncologist in my primary. So how do I get them to want to move forward because I'm still sick, but I'm stuck?
I have thoughts, but
I just want to go on record wanting to hear Dr. Paulson's thoughts on this.
Every situation is very unique. Every situation is very unique. If you, and I'm certainly not going to pry into the situation, but let's say that you had an ovary removed or a single liver tumor removed and there's no primary identified. We can take a look at that in different directions. You may have symptoms. You may have symptoms of a potential residual neuroendocrine tumor, but if it's not easily identifiable on even our best scanning techniques, then there's a lot of harm that can come in trying to identify that, and it may not be our best approach. I have certainly seen folks harmed in many different ways trying to uncover potential tumors that could be there or not, in which case, if there's ways to alternatively manage symptoms, we may not want to necessarily dig and move forward. If there's evidence that the tumor is circulating, that it has landed in other places, I said earlier that a lot of us are not necessarily convinced that eliminating that last potential source is going to be the difference between necessarily your overall outcome. So there may be perfectly sound reasons why they would not want to. There may be some perfectly sound reasons why they're not right and not doing so. It's very individual.
If I could piggyback on this question and toss it to Dr. Chasen for just a moment. So a common question we get in situations like this would be around types of imaging that people can pursue, and specifically, I think some of the risks of false positives and false negatives that come with some of our advanced imaging techniques. And I wonder, Dr. Chasen, if you want to touch a little bit on some of the areas where we can find false positives and how that can affect folks if we sort of deploy the wrong test at the wrong time.
Yeah, that's for sure. I mean, you've heard that there's a bunch of different types of imaging you might get. You might get a CT, you might get an MRI, you might get one of the nuclear medicine studies, PET CT, so forth. And anytime you do a scan of any area, you're going to see everything that's in that field of view, we call it. And then as imagers, we have rules about things that we need to talk about. Or so you'll read your reports and it'll say, oh, there's a 5 millimeters, something in the liver, too small to characterize, or there's something here or something here. So, and people have different thresholds also, because we're all different types of people, and some people are more comfortable saying that something is benign and you don't need to worry about that in the future, depending on experience or just who they are. And other people are very rigid about saying how everything should be followed and what it could be. And I don't know, you might get a report where they list 5,000 different things that this could be, and that becomes not helpful. So, yeah, you can be over-imaged for sure, because they find something and then they think, oh, maybe you could take a look at it with this, and then they're not definitive, and then we look at it with something else and they're not definitive. So that can be a definite challenge.
And as Dr. Paulson alluded to, that leads to needles going places and other things that I think make folks get concerned. Sorry, all I was getting at is when you find a bunch of barnacles on imaging, you can end up, the only way to definitively know sometimes is to start getting invasive with needles and laparoscopes and other things that obviously, we love those things in the right context, but you don't want to do more harm than good and take on unnecessary risk for someone.
When NetSpot became available and DOTA-tape PET imaging and more advanced and sensitive somatostatin receptor techniques became available, for about 2 years, I'd say, my most common consultation was somebody who was completely asymptomatic, feeling very, very well, and had been for a number of years. And now that there was new technology available, got a DOTA-tape PET and had something new on it that probably was there for a long period of time.
That's still my most common consultation.
It's thinning out a little bit because everybody's gotten their PET by now. And look, I think it's one of the most important technologies that we use. So I don't want to try to sound like I am saying this is not an important technology. It is significantly critical. Dr. Maxwell is not going to take you to the OR ever unless she's got one of those up on her screen to take a look at, right? But that was the most common thing that I've seen, and I will tell you that is very destructive from an anxiety standpoint, and it didn't necessarily change what we were doing. So remember, everything we do can cause you harm. We don't intend to. We've already told you our goal is to help you live as long as possible with the best quality of life, but everything we do can hurt you. Biopsy can hurt you. A scan can hurt you by getting you an unnecessary biopsy. We've all had that happen. We've all had somebody be significantly injured or, frankly, die from things like biopsies. No test we do is perfect. There's no test that is perfect. DOTA-tapes can be wrong, even in the best of hands. CT scans can be incorrect. MRIs can miss things. They can identify things that aren't real or a problem. And we know this because we deal with 30 of them a day. But it's your scan, right? And so everything that you're going to see on that, we have to, you're looking at it in the context of, oh my God, this could be a tumor that they're leaving there. And we're looking at more in the context of, boy, the last time somebody had a millimeter thing in the liver, they got a needle put in it, almost bled to death, okay? And I'm being a little bit melodramatic, obviously, for the purposes of the point. That's not necessarily the real clinical situation, but that's kind of the differences and why you may not see a more extreme approach to working things up.
Yeah, just a quick question on PRT retreatment. Oh, okay. Thanks. Yeah, quick question on PRT retreatment, how often that's done. Is it FDA approved? Are all institutions doing that? Or how is that working? Thanks.
I want to get two.
Yeah, everyone wants
So whenever you have any kind of drug or material, whatever, approved by the FDA, it comes with certain guidelines. So the package insert and it says it's supposed to be 4 cycles, 2 months apart, and that's what you do. But we always have this ability to do what we might call off-label, right? So it's not officially, I guess, sanctioned by the package insert to say that you can be retreated with Lutathera once you've already had 4 cycles, but there's nothing that makes it I guess, against the law or malpractice or anything like that, because there is the discretion of the physicians to decide that that could be your best course of action, and it's already an approved medication. So that's where it gets a little tricky. So why at Anderson have we decided that we're going to try certain patients with more cycles? Well, because they did really well on it, and it looks like they could tolerate it again, and we don't have anything maybe different to offer them at this point.
No, and I would just say this kind of gets into the zone where there is some evidence, sort of particularly in Europe, which I believe you cited some of that, Dr. Chasen. But so it's in the zone where there's evidence on which some people will base some of their decisions. The challenge is, whenever you're dealing with evidence that is retrospective, there's always a bit of qualification and sort of trying to customize and make sure that you're using it the right way at the right time. Fortunately, this is a space where there's active clinical investigation going on, and so the hope is that we'll really define the role of, additional radiotherapy of some form after that initial course of 4 that most folks are getting. Does that answer the question well enough? Okay.
I'm going to have question over here.
Does anyone has experience with SBRT as therapy for NETs and how it works out or not?
I've had a few patients who have symptomatic, usually bleeding pancreas neuroendocrine tumors, and they're not candidates for an operation for whatever reason, and that's a way to sort of palliate those symptoms, meaning make that better. But at least in my practice, we don't use it as a matter of course.
It's really not a common thing for liver. There's an occasional time that we will consider it depending on the position in the liver relative to structures that we think are critical. So yes, there's a role for it. It's just not always one of the most common things.
How about the lung?
Lung, so yes, too, although there's not a lot of data. Okay.
That's what I find.
Yeah, there's not a lot of data, but there's a number of different centers. You guys probably do less SBRT than most, and so do we. We tend to fall in the same category on that. But there are some centers who do a fair amount of SBRT for the lung. There's just not a lot of data. It's reasonable.
I recently had a rectal neuroendocrine tumor. It was very small, found during colonoscopy, I think was fully resected. And I've gotten contradictory advice as far as whether or not I should get a scan. Would there be anything wrong with maybe, in listening to you guys talk about what can happen if you see things that are false positives and all of that, would it be beneficial to maybe get a baseline scan and in case you had problems in the future, something that can be compared back to?
Why are you looking at me on that one? That's a tough question.
That's why I'm looking at you.
Yeah. So it's controversial, and you're going to get contradictory opinions on that with good reason. In general,
I disagree with you on that topic.
In general, with very low-risk lesions, a scan is not necessary. I don't fault individuals who obtain it, but for low-risk, small-sized lesions, you are statistically more likely to be injured with a scan, and we talked about how you can be injured with a scan than you are to be benefited from it. So that being said, everybody hears a story of, well, somebody had a low-risk lesion and it was actually bad, and then it's an exception that proves a rule, okay? If folks have scans, I'm always happy to walk down and interpret that with you, but most of us stray away from it depending on the nature of the lesion.
Yeah, no, I was actually just going to say that, and all kidding aside, I actually agree very much with the sentiment you're expressing, right? So low risk doesn't mean zero risk, right? That's always the problem. And so we do our best to offer the guidance based on how low we think the risk is. And as you say, there will always be some reasons in some cases that some may find something to be slightly higher risk and therefore advocate some imaging. I think then you get down the rabbit hole of which imaging is most appropriate, and it depends, right? It depends on the details and all that risk tolerance sort of stuff. And I don't know, Dr. Chasen, I don't mean to cut you off, but
So, I mean, one thing to just realize is that having worked as an imager in ERs and all kinds of places, people will fall from standing and be scanned from head to toe, basically, in that ER. So, and sometimes you find things, like we see a lot of patients that they find, you're in this small minor vehicle accident and you've got a renal cell carcinoma and we found it early, or whatever, or Representative Castro said, a neuroendocrine tumor. So I think that if the imaging is done well enough and you have a good enough reader, I don't know. I guess I'm one of those people that I would want to know, right? Just go ahead and scan me. You would have scanned me if I had this, I stepped off the curb wrong. You were going to scan my whole body anyway. So, yeah.
If patients are sent to my clinic either with duodenal or rectal neuroendocrine tumors, I tend to get a baseline scan, at least of that region of the body. I would be more interested in that depending on your path report. Like if you have lymphovascular invasion, if you have a positive margin, even though sometimes endoscopically, right, when they grab these things, even though it's a positive margin, they burned that margin, so those tumor cells are gone. It's not truly positive. But like if you're coming to a surgical clinic, I'm gonna take a look at least once, and then, we can stretch that out as appropriate.
I'd like to make an observation to specialists, and that's why I'm here, is that for those of us who have come up not seeing specialists initially, who think they know more than they know, although you all realize there's a lot that you don't know, we can often be told, and you've said it, don't worry about this. You've got the good kind. It's not really cancer. It's not really whatever. So when anyone tells you, I've been told I'm okay, you don't know who told them they're okay. You really don't. And you have a lot of faith in other physicians' knowledge that perhaps they just don't know, and they don't know they don't know. So please consider that when you hear someone who's been told, you're going to have a great life, don't worry about it, because we don't know what's circulating in your body or what's in my body until someone who knows the nuance of this disease is so vast. And that's why we come to you, is because it's what you do every day, but it's not what Joe Blow in Timbuktu does with an endoscopy.
And sorry.
Or his pathologist.
No, I obviously have a lot of thoughts on that.
No, so you hit on something that resonates with me because I see it every day, and I do want to say that kind of one of the great challenges that we encounter is that the systematic approach, which is largely appropriate, the line about the ER doc isn't thinking about a neuroendocrine tumor, right, sort of rings in my ears, that we actually as a medical community systematically erode people's trust by the time they end up in my office. And I think it's a real thing to kind of think about that comes into that exam room with you by the time that you're meeting someone who does do it all day, every day, and to kind of think about the way that then affects that relationship and your thinking and sort of the process of working things up from there is that embedded mistrust by the time you've gotten there, often because someone said something that turned out to be wrong. And it's comments like that generated. And so that systematic erosion of trust is very real, and it's in the exam room with us every single day, and worth confronting together, I think.
It's tough, and especially if you're in a community oncology office, right? The relative prognosis relative to some of the things that they're seeing is very different. And most of the time they're making people feel really awful all day by the news that they give, and they like to give some good news. Like there's a good chance that you could be alive for decades with this disease. I already said I don't give prognosis. I think whenever I meet with somebody for the first time in my office, I know that the only thing they're sitting there looking at me thinking is, how long am I going to live? How long am I going to live? How long am I going to live? And I can tell you, I just don't know. We want to try to make you feel better about the diagnosis. So if I think somebody has a really low risk lesion, I'll try to say, you know what, don't change your life plans, but sometimes I'm really wrong. Sometimes a tumor behaves very differently from how I think it's going to behave, even with all the tools that we have. Sometimes you need a lot more aggressive treatment than just sitting and watching. Sometimes aggressive treatment injures folks. So I think you're absolutely right. It's a uniquely psychologically difficult diagnosis in oncology, I think, different from a lot of other types of cancers in that regard. They're very heterogeneous. Their behavior is very different. And it's challenging to get those questions that I think are most important to you answered and answered well, even if we do it all day.
I think we have time for one more. Do you have?
We got some written down ones.
We also have at least one hand up.
Yep.
NetRF or whoever has that list of net specialists, that you record and document how much time they spent with their net practice. I think that's a really good indicator of when we're making a choice.
I had a question about what have we seen in medical training for patients with neuroendocrine tumors? What have we seen in changes? Teach a lot of medical students. It's not a huge part of their training. I hate to break it down like that. It's just not. What I think is critical for the field is patient advocacy, helping to facilitate and move the field forward. The net community is kind of an interesting and fun one. You know, we all argue with each other, but we all kind of get along for the most part. And so those kinds of things is their own little niche. And it's not necessarily a huge highlight in medical training because you have people doing a lot of different things.
There's a real opportunity, I think, for patients to extend that advocacy, though, to the medical school environment. You know, med students anymore, a lot of their training involves, you know, practice patients and different patient panels and things like that. Medical students love talking to patients because they want so much to take that next step, right? And neuroendocrine patients traditionally have this great community and are very active. And if you guys are involved in panels like that, then you might be that spark that gets them excited about learning more about neuroendocrine disease and treating neuroendocrine patients. I mean, I'm a neuroendocrine surgeon because my boss and my mentor at Iowa was a neuroendocrine surgeon, right? I was told it was going to be a hobby, but, you know, every once in a while you're able to make it work. You know, and that's what we have to do. It's responsible. We're responsible for mentoring them, but if you guys can get them excited as well, that may be all that it takes.
I didn't even know what nuclear medicine was as a medical student, so my kind of whole field suffers from that. I didn't even find out about it, just fell into it.
Yeah, what do you guys do back there anyway? I still don't know.
We radiate stuff, you know. It's, and kind of going back to this idea, I mean, I think it's really great to have a specialist, and everybody up here is a specialist in that, and that's awesome. But I do want to say, like, you don't want me to read your cardiac scan, right? Or you know, if you have hypertension, you maybe don't want that handled by one of us up here. So it's like I don't want to say that, you know, everybody out in the community, you know, is no good or whatever. People are really good at different things, and we do need people who are good at a variety of things, but then who know enough when they don't know enough. And I think that's one of the things I've noticed. Everybody up here is kind of like, you know, there's all this stuff I don't know. So my word of advice would be if you run into a doctor who is always very confident about everything, it's probably the wrong doctor.
I think that's a good final thought.
Okay.
So I want to thank our panelists, our NET specialists, for being with us. And also, you know, follow up on some of the comments. I think one of the things that you can all do as advocates in your community, in the health system that you use for your health care, if you're willing, tell your story. You know, I think it's a great comment to talk to medical students. I also suggest that people find perhaps some of NetRF's grantees, and they may work in a laboratory all day, and they may not have a lot of opportunities to talk with patients. And I think it makes it real for you to talk about your experience with someone who works with mouse models or with cells all day. It really, it builds this community, and this is a special community. We see it every day. We know really how important it is to you to get an education, and also know, again, as I said earlier, know what is happening in research and how many people are trying to unlock the mysteries behind this really, really challenging disease. So all of you deserve a round of applause because you stayed in for the entire afternoon, so thank you.